Okay, hi. I'd like to thank everyone for being here today. My name is Lexi, and I'm currently a graduate fellow with CRISP. Today is the second of four webinars related to the Maryland Model Analytics Project. For some background, the Maryland Model Analytics Project set out to evaluate specific aspects of the Maryland Total Cost of Care model and care transformation efforts. CRISP sent out an RFP and contracted with multiple vendors and stakeholders to address investigative analysis questions regarding care design, potential best practices, and areas of improvement. Some background for today's webinar: Maryland has an arrangement with the Centers for Medicare and Medicaid Services regarding hospital reimbursement based on a fixed global budget to avoid unnecessary inpatient utilization. This webinar will summarize the results of an investigation that analyzed Maryland's hospital performance across different types of inpatient stays and compare that performance to hospital performance in other states where that specific CMS reimbursement arrangement is not implemented. We do ask that you hold questions until the end of the presentation, but feel free to put them in the chat or after the presentation. If attendees would like to unmute themselves, they may. And with that intro, I will turn it over to Acumen. We have Joyce Lamb and Sam Bounds here today. Both will kind of talk over the presentation and be on here to answer questions. And they will be presenting on the evaluation of Maryland Medicare spending on inpatient care. So again, thank you. And Joyce, whenever you're ready.
Great, thank you. Hi, everyone. Thanks for the intro, Lexi. So I'm Joyce Lamb from Acumen, and I'm here with Sam Bounds. We've been working on this over the past months or so, and we're excited to share our findings from this. So we'll jump right into, let's see if I can make these slides. Oh, okay, great. So this is just outlining what we're going to cover today. And really spend the most of the time on the findings. So as you all know, Maryland has an arrangement that differs from other states. So this is just background, which we'll skate over since Lexi already introduced this. And really the focus of what we have been looking at is analyzing cost performance. So we looked at inpatient stays in Maryland compared to other states, and we use different levels of analysis and different levels of granularity, such as ways of categorizing stays so that we could do comparisons at these different levels. And then we also looked at a range of associated metrics of cost and resource use that really helped to build out the picture of are there differences between Maryland and other states in terms of inpatient care and spending. So first, we'll just highlight some of the methodology in terms of how we approach this. So for data sources, we used the CCW, the Chronic Condition Warehouse, looking at Part A and B claims. We looked at the beneficiary enrollment data on CCW. One thing to note is that for cost variables, we use the allowed amount. So that means it's not the standardized allowed amount. So payment standardization is a process for removing geographic and other sources of variation in costs that are unrelated to care decisions, such as CMS incentive payment program amounts, things like graduate medical education. So we are using just the allowed amount, not the standardized allowed amount. So that's just something to keep in mind. For sample, we use all beneficiaries in Maryland, and across the other states, we used a 5% sample. And the study period was looking at inpatient stays ending in 2019 to avoid looking at the disruptions from COVID and the public health emergency. So the next couple of slides look at the metrics that we've included. So the first is increasing levels of, at aggregation. So at the base, we have Medicare Severity Diagnosis-Related Group, MSDRGs. So these are the most granular way of looking at inpatient stays. So these are defined based on information on inpatient claims, looking at principal diagnosis, secondary diagnosis, surgical procedures that took place during the stay, discharge status. So all of this information on inpatient claims is used to categorize stays into particular MS-DRGs. And the MS part of this indicates severity. So there's complications and comorbidities, which you might see later on as with CC, or major complications or comorbidities as with MCC. So the severity level, these are reimbursed at different rates. Then you can roll up the MS-DRGs into major diagnostic categories, or MDCs. So there's about 26, which are mutually exclusive and exhaustive ways of organizing the DRGs. And so some of these are related to organ systems like eye, respiratory, musculoskeletal, or for particular conditions or reasons for needing inpatient care, like burns, traumas, different types of diseases. Another way that you can look at MS-DRGs is medical versus surgical. So surgical stays, these are determined based on procedures that happen during the inpatient stay. And so there's a hierarchy, since folks may need a range of different procedures during a stay. So there's a hierarchy included in the algorithm for determining which surgical stay it should be categorized into. The last row here in this table is something that we implemented to try to take into account the fact that Maryland and other states have these different payment systems. So what we did is we looked at the ratio of the cost of inpatient stays to the mean cost of all inpatient stays for either Maryland or for other states. So what this does is that it helps to neutralize some of the fundamental underlying differences in the payment system, so that we can have something that allows us to compare costs while controlling, to some extent, some of these. Then we included some other metrics which help to build out that understanding of what's going on with inpatient care, because obviously hospitalizations don't happen in a vacuum. So the first is looking at 30-day post-discharge spending. So we looked at all the allowed amounts for inpatient, outpatient, Part B physician supplier claims for 30 days after discharge. So there's a couple of ways we did this. We looked at this just looking at the post-discharge spending, and we also looked at the inpatient stay plus the post-discharge spending. So a metric like this is interesting to look at. There are some limitations which we'll talk a bit more about, such as because we're just looking at all inpatient, outpatient physician supplier claims, this doesn't tell us anything about how, whether or not those costs are related to the hospitalization itself. It also obviously is only those particular settings, and there's other types of costs, such as DME, post-acute care, which we are not picking up here. Then we also looked at length of stay. So we have some interesting findings showing the different trends in how the inpatient stays, how the breakdown of length of stay looks for Maryland and other states. We also looked at the share of stays within a base DRG at the different severity levels. So where you have a DRG which offers the MCC, the major complications, comorbidities, and complications, comorbidities, we looked at what share of those fall into each level of severity. So this can get to questions of differences in patient case mix. Finally, we looked at the number of ICD-10 diagnoses in a 120-day look-back period. So this is looking at patient complexity. So any differences in cost, we will want to control for differences in severity, patient needs. So this was a proxy for getting at that question of how healthy is that population. So what we did was we looked at the diagnosis codes, but we aggregated them to the 3-digit levels to account for differences in the level of specificity. So where 3-digit diagnosis codes, we grouped together where there might be a number of 5-digit diagnoses that are all kind of related to the same condition. So these are the metrics that we looked at for our analysis, and we can jump right into what we found. So this slide just outlines the major categories of what we looked at. So we're actually going to go in the descending order. So we'll start by looking at MDCs and then gradually break down to the more granular levels of MSDRGs. So first, when we're looking at the cost of inpatient stays and looking at the MDC level, we found that Maryland has higher mean inpatient spending across all except for one MDC. And the one MDC where Maryland had a lower mean inpatient spending than other states was MDC 22 for burns. When looking at patient complexity, as shown through the number of 3-digit diagnosis codes, across MDCs, we found it's mostly similar for Maryland and other states. The difference between them usually is plus or minus 2 diagnosis codes. And generally, this result is something that we expected to see, where Maryland pays higher rates than CMS's IPPS. So the fact that we saw higher spending across the MDCs is not an unexpected thing. One thing we did find is that Maryland inpatient costs had more variation than other states. So looking at the standard deviation is higher for Maryland than other states, which indicates there's greater variation in the allowed amounts from the mean. And so for most of the MDCs, the cheaper hospitalizations are less expensive in Maryland compared to other states, while the more expensive hospitalizations are costlier. These results are also not unexpected, where the way that Maryland's payments are set up is that it makes it more sensitive to the actual services delivered. So this is something that can drive more variance at the two ends of the distribution. Then we looked at that breakdown of medical versus surgical stays. So this chart just shows what this looks like for Maryland and other states, where it's fairly similar, but Maryland has a slightly higher share of medical stays than other states, with 74%, while other states have just under 71% of their stays as medical. Looking at the number of prior diagnoses, it's fairly similar. So for medical, both Maryland and other states have a mean of 29 diagnoses. And for surgical, Maryland had a mean of 24, while other states had a mean of 23 diagnoses. When we're looking at spending for medical and surgical DRGs, we saw that Maryland's mean allowed amount per inpatient stay is greater than other states. So here, that's in the first set of rows, so 17,704 compared to 12,655 at the mean for medical. So that's about 1.4 times greater for Maryland than other states. And for surgical, the amounts are higher, but the difference is slightly smaller, where Maryland's mean spending for surgical stays is about 1.3 times than other states. Then we looked at the most granular level, so looking at each of the MSDRGs. So given the results that we saw at the MDC level and looking at medical and surgical, Maryland has higher allowed amounts for inpatient stays for almost all of the MSDRGs. There are 6 MSDRGs where Maryland has a lower mean allowed amount than other states. And the next slide shows these costs, but only one of these has a statistically significant result for MSDRG 895, where at the mean, this was a statistically significant result. One limitation to keep in mind is that all of these days have some pretty low counts, but we thought it was interesting to look at nonetheless. So these are the 6 MSDRGs where Maryland's mean inpatient allowed amount is lower than that of other states. And so this is shown as Maryland's spending as a percentage of other states. So you can see for 895, the alcohol, drug abuse, or dependence rehabilitation therapy, this one has the largest difference and the one that's statistically significant, where at the mean, Maryland's inpatient allowed amount is 75% of other states. Then we looked at that metric that I mentioned, where we took the ratio of the stays costs to the mean overall stay cost for Maryland or for other states to help neutralize differences in payment systems. And what we see, as we've seen in some of the other results, is that there's greater variation in spending for Maryland than other states. So here we can see, looking at medical and surgical, that the ratios are lower at the low end of the distribution and higher at the higher end of the distribution. So what this is suggesting is that the spending at the right end is pulling up the mean. So this was something that is interesting for us to look at, to try to back out some of those differences to see what the differences in spending are, keeping in mind that what we were working with is just the allowed amounts and not the standardized costs. We looked at MDCs, so focusing on the higher frequency MDCs. So here we looked at MDCs where there were 10% of stays falling within them. So really focusing on what's high volume in terms of inpatient care. And so when we looked at the ratio, we can see that comparative to the mean inpatient allowed amount, Maryland spends more for respiratory and musculoskeletal than other states, and less for circulatory diseases and disorders and infectious diseases. So that's what we can see here in the ratio in the mean IP state. And again, looking at the distribution, where it tends to be lower at this end of the distribution and then higher at the high end for Maryland. Then we also looked at the MDCs where there's the largest difference in the ratio between Maryland and other states. For those, most of them had pretty small counts. So we focused on the ones where there were more than 1,000 days in Maryland. We did see some differences for MDC 23, but we didn't include that in this table here because there's a lot of heterogeneity in the types of MS-DRGs which fall within that MDC. But for these two MDCs where there was a large magnitude in difference between Maryland and other states, we see for 17 and 19 that the difference at the mean is quite large. So for MDC 17, the ratio for Maryland in terms of the allowed amounts compared to the mean across all IP stays is 2.45, and then for other states it's 1.96. So these were some of the larger results that we saw when looking at this ratio of allowed amounts to the mean for across all states. So that is a quick overview of what we saw for looking at the cost of inpatient stays. And now we'll go into some of the other metrics that we looked at that help build out that picture of inpatient spending, patient complexity. So starting with looking at what's going on after the hospitalization. So we looked at the 30-day post-discharge costs, and this was something, well, it's on this and the next slide, where this slide is looking at just the distribution of inpatient stay allowed amounts. And so as we saw before, it's higher in Maryland than for other states. So here in the bullet points, we see medical is about 140%, surgical 130%. And then when we add in the 30-day post-discharge costs from inpatient, outpatient, Part B physician supplier, what we see is that the difference between Maryland and other states actually decreases. So for Maryland and the medical stays, the difference is now 125%, so a drop in 14 percentage points. And for surgical, it's 126, so a decrease in about 7 percentage points. So what this is showing is that the difference in spending between Maryland and other states actually decreases when we're looking at what happens after the hospitalization. So the limitations that I mentioned is that this doesn't take into account the higher costs of Maryland hospitalizations, which we know. So if there are readmissions happening downstream of a hospitalization, those are being picked up as higher costs here. And as I mentioned, this doesn't show relatedness of these post-discharge costs to the hospitalization. So these are just there's some limitations to keep in mind when looking at these results. Next, we look at the length of stay between Maryland and other states. So this shows the breakdown across all of the states, for Maryland in blue and other states in red, with these two vertical lines showing the means. So you can see Maryland, with the blue, it has a higher mean length of stay than other states. So we looked then more into particular MDCs to see if there are any particular trends of interest. And the next couple of slides show the same breakdown, but limited to particular MDCs, where we did actually see some pretty interesting results in terms of the trends being quite different. So there were 3 MDCs where Maryland has a much greater share of long stays than other states. And this is the most obvious for MDC 19 here at the bottom for mental diseases and disorders, where for Maryland, it really kicks up for the over 21-day stays. So really, Maryland has a much greater share of the very long stays here. And we see that to a lesser extent for MDC1 for diseases and disorders of the nervous system when compared to other states. And we also see that for multiple significant trauma, where Maryland, you can see, has a increasing share as we look at the number of days for length of stay. Then another one where we saw a different trend was for MDC 20 for alcohol drug use, where Maryland has a lot more short stays. So compared to other states, there's a spike up at 4 days and then kind of tapers off, where Maryland has fewer of the longer stays than other states. So these were the MDCs where the results showed some different trends that we wanted to highlight. Then we looked at the Medicare severity level, so the MS part of the MS-DRGs, focusing on the most frequently billed DRGs across states. So we looked at the 10, where there's the highest numbers of stays, to see how does this compare in terms of the share of stays falling within each level of severity. So we've got all of these listed here. So the lowest severity is the third one in each of these sets of columns, without complications, comorbidities, and without major complications and comorbidities, where with MCC is the highest level of severity. So we have the columns here for how this looks for Maryland and other states, and the share of stays within that overall base DRG falling into each level of severity. And what we found was that for 8 of the 10 DRGs with the most frequent stays, Maryland had a smaller share of stays falling into the highest severity levels. So for example, looking at the first one for intracranial hemorrhage, cerebral infarction, a stroke, you can see that Maryland had 32% of their stays at the highest level of severity compared to over 35% for other states. So this final column is just looking at the difference in percentage points for the share of stays falling into that highest severity category. And so that here is a difference of 3.5. We've highlighted a couple here where the differences are pretty big. So here for simple pneumonia, where the difference is over 15 percentage points. So in Maryland, 38.7% of the stays within simple pneumonia and pleurisy were at the MCC level, compared to over 50% for other states. So heart failure, we saw also a pretty big difference, and kidney UTI, which was over a 14 percentage point difference, where Maryland had a lower share falling into that highest severity categorization. So there were only 2 where Maryland had slightly higher shares, and you can see here for COPD and cardiac arrhythmia, and the magnitude of the difference is quite small. It's 1.2 percentage points for these. So that brings us to a summary of our findings and some thoughts about the limitations to keep in mind for these analyses. So certainly some ideas that we've had for potential future research could be to increase the sample size to look at 100% of beneficiaries in other states, and also to look at additional years, since we were looking at just inpatient stays ending in 2019. Another enhancement could be to look at payment standardized costs to remove some of that variation that's unrelated to care decisions, to provide another way of looking at costs. And one thing that could be good to look at is also accounting for patient complexity using a risk adjustment model. So that would neutralize the differences associated with patient complexity and patient case mix. So there could be something that's more enhanced than looking just at the number of prior diagnoses, such as focusing on diagnoses that indicate severity of where it's expected to have an impact on costs. And then the other idea is building on some of the metrics that we've looked at, which is to look at patient outcomes. So that idea of looking at what happens after a hospitalization, where we could explore that in more detail. So this slide just summarizes what we found for each of the levels of analysis. So in general, as we expected, that Maryland has higher inpatient spending than other states, has more variation, and that the difference in Maryland spending actually decreases compared to other states when we're looking at inpatient stays plus the 30-day post-discharge inpatient outpatient physician supplier costs. The length of stay is generally higher in Maryland, with some types of stays, such as the MDCs that we looked at, having some pretty markedly different trends in terms of Maryland having a much higher share of very long stays. And then looking at base DRGs and the share of stays falling into highest severity categorizations, Maryland has a lower share for 8 of the 10. And the difference of these is quite large for some of those DRGs. And just finally, the idea that these analyses can be refined to take into account patient complexity and some of the other ideas for neutralizing differences in payment and looking at other outcomes alongside costs that can help shed some light on inpatient care. So we got through everything in half an hour, and we're happy to answer any questions that you might have.
Thank you, Joyce, and thank you, Acumen, so much. We really appreciate that presentation. For everyone here, so this has been recorded and it will be available on the CRISP Learning System website. And then the actual full report is already available, and I will put that link in the chat in a few minutes. So now for questions, you guys can put it in the chat or unmute yourself. I know I already have 2 questions ready, so I can just start with the first one. Acumen, which is a clarification. Jackie Ward was asking if she was kind of understanding what you were saying correctly, that Maryland inpatient costs were higher than other states, but lower costs after discharge.
Yep, that's a correct interpretation. This is Sam from Acumen, by the way. What's important to note is that the stay plus the post-discharge spending is still higher for Maryland compared to national. But what we're doing is a diff and diff comparison here, in that difference has decreased when we've added the additional longitudinal assessment of cost post-discharge, which is promising. It suggests that while we know that the inpatient stay is more spending at Maryland, that the cost shift to subsequent care post-discharge seems to be catching up in Maryland. And that while the spending is higher, its slope is more subtle than that of the nation, is how I'd describe it.
Thank you, Sam. So it looks like our next question is from Heather, and she is saying, did you see any signs that recent innovations implemented in Maryland may not have fully manifested in spending yet? For example, lower rates of severe pneumonia admissions could be signs of improvements in population health management of respiratory conditions. Did you see any trends indicating potential for future spending reductions that aren't realized yet?
I really like this question. The answer is we don't have analytics to look at this yet. I mean, my first inclination is a more longitudinal assessment over time. But I think your intuition and kind of research idea is right here. And that, it's promising. It's really promising to see the lower severity utilization in Maryland, especially with pneumonia, but to see those future savings, the best way to just look at it directly and assess things in 2020, 2021, and 2022. Now, especially with respiratory conditions, COVID's going to throw a little bit of a wrench into that plan. But a long answer to say, no, we don't have those findings today or through this experiment, but a really interesting line of research that I think has potential.
And one thing that I'd also mention is to provide a plug for next week's webinar, when we'll be back to talk about another study that we did looking at chronic conditions. So it doesn't directly answer this, but if you're interested in what we found in terms of spending looking at chronic conditions overall, not just focused on inpatient care, we encourage you to come along to that.
Thanks, both Sam and Amy. Our next question, or sort of a clarification, Katie is saying it looks like the analytics were not population adjusted and the volume stats appear to be absolute value and not per capita calculations. Could you talk on that?
Most of the cost figures are per stay calculations, which would adjust for the stay count, provided there's a sufficient sample and both that we're looking at. In terms of some of the other volume statistics like readmissions, we looked at readmissions, we looked at mortality, we also looked at like proportion of stays. We did relative comparison. That's why a lot of the times we're looking at point differences and percentages to do share comparisons. That's one way to somewhat adjust for population. And another way is we did do in our report, though it's kind of similar to doing share comparisons per 100,000. So we do have some of those adjusted stats in the further report and data supplements, but I think that's a good observation.
Thanks, Sam. So next question is from David, and he's saying, for length of stay, did you or can you assess post-acute resource availability and acceptance? We believe part of Maryland's LOS issue is contributed to barriers imposed by post-acute facilities and accepting our discharges, thereby increasing our patient LOS.
For this one, the short answer is no, we didn't look into this. And we were limited to looking at inpatient, outpatient, and Part B physician supplier. So we didn't look into post-acute care in particular. And I think looking at availability is something where we might be able to do something looking at the, say, correlation if we have particular geographic areas, but it's not something that we did for this analysis.
Okay, thank you, Joyce. Next question is from Rich, and he is saying, is there any considerations to demographic variances between Maryland and national average demographics? For example, age, urban, rural, etc.
Partially. We have age and gender. We didn't see any substantial differences between Maryland and other states, but in terms of more demographic variables, I think there's a lot of other ways to cut up beneficiary characteristics. Those are kind of limited at this point.
And it's something that that looking at a risk adjustment model could take into account. So not just looking at patient complexity, but also looking at age bracket breakdowns and other Benny characteristics is something that could be tested.
Thanks, Joyce and Sam. Our next question is from Dale, and he is saying some of the distributions were skewed. Can you report the median in addition to average?
Sure thing. Where we could in the slides, we tried to add the distribution, and in the report, I hope we include the full distribution as well. If there's specifics, we'd be happy to supplement them. We always do the full distribution. And this is also a really nice, astute observation of the skewedness. I think that's kind of part of what Joyce was pointing at in the difference in variation, where like at the 10th percentile, Maryland is actually cheaper, and the potential for cost savings could be in that right tail, and that right tail for Maryland is quite dramatic. In some places, the medians are rather close, and so I think it's a real good comment and reminder from Dale. Thank you for that.
Thanks, Sam. So that looks like it was our last question in the chat, unless anyone else has anything that they would like to add. But otherwise, I would like to thank Acumen for being here today for this webinar, and our next one will be next week. Jessica did put the link to register in the chat. So thank you, everyone.
Thanks, everyone.